alaikum and good afternoon. Just want to make sure my slides are coming through. Okay. So, like, okay. There's no issues. I think I can. You can. Am I coming through?
Yeah.
Okay. No. Thank you to the organizers, and unfortunately, I wasn't able to be available for the meeting on site. I also think that Mohamed has also thrown me a curveball because unfortunately the evidence for premix insulin is missing, and if we look at our guidelines, we make a clear recommendation that patients shouldn't be on premix insulin. But having said that, a lot of our patients, as our previous speaker has so eloquently alluded, are on multiple daily injections, and unfortunately many of them are also on premix insulin. So I thought we'd go through a case of Musa, a 23-year-old university student. He's had type 1 diabetes for 9 years and has been on premix insulin with Aspart Mix 30. And his current dose is 3 units before breakfast, 20 units before supper. He has occasional hypoglycemia, but he says these are usually when he skips a meal or delays his meals, and they occur about twice a month. He checks his glucose 3 to 4 times a week. His last diabetic ketoacidosis or admission for hypoglycemic emergencies was about 3 to 4 years ago. And his current HbA1c is 9.2%. He was previously struggling a bit more, and he's now coming down from an HbA1c above 10%. He has no evidence of complications in terms of albuminuria, normal no retinopathy, and a normal foot exam. But he comes to you saying that he's been told by his healthcare practitioner that fasting is dangerous for type 1s, and he has now heard that perhaps this is not true. So when we first see Musa, the first thing that we'd have to consider is what is his risk for fasting? So we look at his, so when we take the new DA risk stratification tool, he scores a point for having type 1 diabetes, an HbA1c greater than 9%. The fact that he's on multiple daily premix insulin scores him 2 points, and the fact that he has occasional hypoglycemia accrues half a point. In terms of his monitoring, it's indicated, but he doesn't conduct it optimally for somebody who's on twice daily insulin, and especially premix insulin, so he accrues 1 point. And when we then look at prior to this evaluation, Musa has never had focused education for Ramadan fasting, so he accrues an additional point. So when we put it together, Musa comes through with a score of 6.5. Now, when we then go to the risk categories, a score of 6.5 would then confirm Musa as being in a high risk, and the recommendation would be for Musa not to fast. Now, I often think that there's an additional use for the DA risk stratification tool, in that it also points areas where we can actually adjust an individual's risk of fasting. So the issues that we need to consider when we're managing Musa is, can we reduce his risk of fasting? Why is he using premix insulin in the first place? Is he willing to change and adjust his insulin therapy? Is there a way of optimizing premixed insulin if there are no other options? And how do we adjust premixed insulin during Ramadan? So coming back to Musa's case, if you look at the modifiable factors in his management, I draw your attention to the fact that at the moment he's on the highest risk regimen in terms of managing his diabetes. So if we could get ideally Musa to an automated insulin pump, or even at the very least to a basal bolus insulin regimen with an ultra-long acting basal and a short-acting insulin analog, we would at least cut his risk by half a point. If we have a discussion with Musa that in order for him to fast, he needs to optimize his monitoring, and that would reduce his risk further. And by providing him structured education, we could actually reduce his risk by up to 3 points and move him into the moderate risk category. So now coming back to premixed insulins. So we know that they are the commonest insulin regimen used in many countries. And the reason for this is generally convenience. It's 1 pen twice a day. And the majority of patients are actually on low ratio premixed insulins, where 25 to 30% is short or rapid acting insulin analogs, and the remaining 70 to 75% are intermediate acting insulin analogs. A smaller percentage of patients are actually using higher mixed ratio, where 50% is basal and 50% short acting. So when we look at the pharmacokinetics of patients, and I draw your attention to the study, which looked at healthy patients compared to those on basal bolus with the glargine-based therapy and Lispro premix insulin. And if you look at the first arrow, you'll notice that starting in the fasting state, they both approximate each other. But then once we get to around the midday, you note that the insulin levels are higher in the patients on premix, and they do not revert back down to the same baseline. So it tells us that those patients who during the midday already have insulin in circulation, which often necessitates the meal. Furthermore, we know that usually a lower dose is injected in the evening, and therefore we see a much lower postprandial excursion of insulin in patients on premix insulin. And this then translates, if you look into the next diagram, it tracks the glucose levels to a higher postprandial glucose level. And this here is particularly pertinent to Ramadan, where patients at iftar often indulge in carbohydrate-rich foods, and this excursion may even be higher. So the challenges of low ratio premix insulin in general means that there's less flexibility in terms of meals. It works in patients with type 2 diabetes who often have much more regimented meals, but in a young patient like Musa, this is often less likely. There are many trials which suggest that it results in poorer control with an increased risk of diabetic ketoacidosis, whether that's because if an individual misses a single dose, he actually misses more than 50% often of his insulin therapy for the day, or is it because the patients who are selected for the therapy are actually those with a higher HbA1c. There does seem to be an increased risk of severe hypoglycemia in analyses, and these risks, however, are less in patients who are on analog insulin premix versus human insulin premix, which is still the case in many of the impoverished countries. In terms of Ramadan specifically, there are certain challenges in that because the ratios are fixed, we may have inadequate prandial cover in the evening for the resultant postprandial hypoglycemia, and the doses of prandial insulin cannot be independently adjusted because it's part of a premix of a fixed ratio. And this leads us to having both the risk of postprandial hyper and hypoglycemia after suhoor, depending on the meal that the patient takes. Because we have those patients who may eat a plate of rice for suhoor, and you have others who may just have a cup of tea. The other problem is, we showed earlier, is there's still some insulin that's in circulation during the midday period, and this relative peak may cause a risk of hypoglycemia during the course of the day. So the question then would come to Musa as to why would Musa be on premix insulin? So we use premix insulin in type 1 diabetes often because it's the only therapy available in resource-constrained environments. It's also, unfortunately, many of our patients with type 1 diabetes do not always access expert physician or endocrinologist, diabetologist, and they may be treated by their primary healthcare practitioners who are familiar with premix insulin for their type 2 patients. We then have patient factors where the patients themselves may be reluctant to inject multiple times daily. And often, if they've started with the premix regimen, they then find the burden of increased injections more burdensome, more cumbersome. There are some patients who find it difficult to cope or to adhere to multiple therapies and the different insulins at different times. And unfortunately, although we would like all our type 1 patients to have insulin pump therapy, this is not practical for the majority. And then changing goals of therapy. So when we have, and this is something we often see in our practice, that we have these patients who really struggle with basal bolus therapy, they often skip, and they become the so-called frequent flyers that they're admitted every few weeks to months with diabetic ketoacidosis. And then the goal changes to prevent their emergency admissions at the expense of long-term control and prevention of long-term complications. And this was the case with Musa, where he was having, during his adolescence, multiple admissions, and the practitioners at that point felt that perhaps giving him a regimen that was simpler may promote adherence, and it did achieve that goal in that he wasn't admitted subsequently with diabetic ketoacidosis, but this was at the expense of tight control. So I'm not going to spend too much time on this point because this was covered very well in the previous two talks, but I just want to highlight the fact that if your patient is going to change therapy, and he is now willing, because Musa has now come to you and perhaps explaining to him that the safety of Ramadan fasting would be enhanced by him changing to a different regimen such as basal bolus, analog insulin therapy, or insulin pump therapy if available. then perhaps this is something that he would consider using throughout the year, and not only for the month of Ramadan. But coming back to Musa, and he tells you that he only wants to remain on his premixed insulin, and he's happy taking insulin twice a day. And then we need to ask ourselves, is there a way of actually optimizing premixed insulin? So the one way would be to enhance our monitoring. And there we would consider utilizing CGM so that Musa would be able to identify when he's having hypoglycemic episodes during the course of the day without the need for frequent monitoring. And that would also give him the confidence to titrate. The other advantage is he would then also see the postprandial excursions, and that may enhance the ability to change him to a more optimal regimen in future. The other option is, or the limitation in the past, was that we were unable to co-formulate glatiramer or glargine with short-acting insulin in a single vial or pen. Now, this has changed with insulin degludec, which can be co-formulated as IDEC-S, where 30% is the short-acting and 70% prandial. Now, we don't have any direct studies of IDEC-S in type 1 patients with during Ramadan. But I want to infer two things from two other studies. So when we look at the IDEC-S study in patients with type 2 diabetes, there was a clear reduction in the overall incidence of hypoglycemia. And I think this is something that would lend itself, because the theory of the degludec pharmacokinetics shouldn't be different between type 1 and type 2 patients, and would minimize some of the peaks. The second study would be the BOOST type 1 study, which was a study looking at patients on basal bolus, conventional basal bolus with glatiramer and aspart, compared to patients on a modified basal bolus where they took degludec, aspart co-formulated for their main meal, and then a dose of aspart for the other meals. And I think the reason that this year is quite useful for somebody like Musa is because he doesn't need the lunch meal, so it still keeps him to 2 injections a day, where he would then take the co-formulated dose at his largest meal, and then a second dose of aspart that could be titrated according to his needs for the other meal. In this study, there was no sacrifice in terms of glycemic control, and there was a suggestion, although not statistically significant, that the co-formulation actually resulted in a lower risk of hypoglycemia. Right, so coming back to Musa, he's unable to, unfortunately, change his therapy because of resource constraints. He's unable to afford IDEC-S pump therapy, and he's not prepared to change to basal bolus therapy. So when we look at how do we modify Musa's therapy, we then need to look at his dietary education. Can we get Musa to match his meals to his doses as much as possible during the month of Ramadan? Now, we have to understand that this is not always possible. His cultural habits, perhaps eating with friends at certain times, may not allow us to strictly match his meals to his doses. The second component would be to enhance his monitoring. So as we said previously, CGM is ideal. But if this is not possible, then we need to educate him on increased self-monitoring of blood glucose at least 3 to 5 times daily. So we could look at the pre-suhoor and pre-iftar to adjust our doses, as well as morning, midday, and mid-afternoon to try and minimize the risk of hypoglycemia. In terms of his dose adjustment, as we saw, Musa is taking at the moment 20 units before supper and 30 units before breakfast. The recommendation is to take the usual dose at iftar, the usual supper dose, and to reduce the suhoor dose by 35 to 50%. So from a practical point of view, Musa could start with 20 units before iftar and 20 units before suhoor. However, we need to individualize this based on the dietary changes at suhoor and iftar, as well as to the changes to his nocturnal routine. Does he have a usual routine where he actually goes to bed soon after Taraweeh and wakes up and it's really having an earlier breakfast? Or is he somebody who culturally now will spend most of the night actually awake and out with friends, and then only comes back and sleeps most of the day? So these need to be borne in mind. Lastly,
3 minutes. Dr. Nazeer, 3 minutes, please.
Okay. Lastly, we need to look at educating Musa on self-titration. And looking at the algorithm, we need to make him aware that at any significant hypoglycemia, he needs to adjust his dose the next day and reduce the relevant insulin dose by 4 units or 10% if there's a true hypoglycemia, and if it's less than 90, then to reduce it by 2 units or 5%. Our target is between 5 and 7. And if the blood glucose is above 7 millimoles or 126, increased by 2, and above 16.7 or 200 milligrams per deciliter by 4 units. The important thing for when titrating for hyperglycemia is to rather look at the trend for 2 to 3 days instead of adjusting it on a daily basis, because the 1 day may be an outlier. So putting it all together, at the moment, evidence on the use of premixed insulin in type 1 diabetes during Ramadan is missing. And this should be a call to action, because many of our Muslim patients, unfortunately, are not living in resource-rich environments where they have access to insulin pump therapy and CGM. For those patients who are able to, we should aim to change therapy to the safest possible regimen backed by evidence. And here, premixed insulin should be replaced by either basal bolus or ideally insulin pump therapy. And for those on premixed insulins who cannot change, consider degludec co-formulations and enhanced monitoring strategies as discussed, and ensure appropriate education of dose modification and self-titration during the month of Ramadan to ensure safe fasting. And I thank you for your attention.